Good morning, students. I hope you're all doing well. This is Dr. Clinkscales, and I have come to deliver the lecture for Chapter 17 on complications of neonate and nursing care. So I haven't done voiceover PowerPoint in a while. I've done a few test runs, so hopefully it'll be good for you guys. So this starts on Chapter 17. In the book, it comes from page 547. So the inspirational saying of the week is going to be, we're all in this together. Let's say this again, we're all in this together. So I think it'd be a good idea if we all start singing from High School Musical. Go ahead, I'm waiting for singing. Eh? How about dancing? This is the thing, when I do voiceover PowerPoints, I still try to make you guys laugh, okay? I still try. I'm sure I'm getting a lot of side-eye, but I still try. But just know Dr. Clinkscales is proud of all of you. I know it's been a hard semester so far, but we're still going and we're still trying. So just keep it up and we've got this. So can we get a ooh, ooh? That was weak. Yeah, I told you, I'm trying to make you laugh. Not sure if you're laughing or crying or just giving me side-eye at this point, but hopefully you're smiling. So let's go ahead and get started, okay? And I hope I'm doing everything right. I hope my voice isn't cutting out, but I've done a few test runs for this. All right, so when I say complications of the neonate and nursing care, what does that mean to you? What comes to your mind? I want you to think back to clinical. Some of the babies that you've taken care of. I'm sure everybody's had a chance to see babies who are preterm. I'm sure people have seen babies who have jaundice. I'm sure you may have seen babies who are large for gestational age, macrosomic babies. I'm sure that everybody, if you've been to NICU, you might have seen babies who might have been on oxygen or CPAP because of respiratory distress issues. So these are things we're going to talk about, because the thing is, we love babies, okay? We love babies. I love babies, but babies can have a lot of problems, and that's due to development or complications of their system. So that's what we're going to talk about today. But it's going to be a good lecture, and hopefully you learn a lot. And make sure you ask me any questions. I'll be happy to go over anything you don't quite get. Ooh, ooh. All right, so first we're going to start on preterm neonates. And as I said, if you're following in the book, we're on page 547. All right, so preterm neonates, this is anything below 37 weeks. So we look at gestational age, because like I said, you can have babies who are super preterm, which we're going to talk about on the next slide, because some babies are below, I think, like 25 weeks. I mean, I have to say the smallest baby I've ever seen was 23 weeks, okay? So, and then you also got to think about the birth weight, because if you are a preterm baby, a lot of times you're going to have very low birth weight. So these are some things that we want to think about, because these can also cause problems, such as with thermoregulation, hypoglycemia, and just other things. You're going to be more at risk for infections. And then we also have stuff like congenital anomalies. So congenital anomalies are things that the baby is born with. Baby may have anomalies of the heart, anomalies of the kidneys, liver, renal area, facial deformities, lung deformities, and these are all things, and some babies can't survive. They may have made it, but they're not able to survive outside of the utero for very long. So that's the leading cause of death. And then you've got prematurity and very low birth weight. Because like we were saying, some babies are really premature. And the more premature, the more chances that you're going to have lower birth weight. And babies may not be able to function, because you also got to think about that certain things may not be, certain organs may be very immature and may not be able to be sustained outside of utero. So these are our different types of prematurity in babies. We have extremely premature, babies less than 28 weeks. And like I said, the smallest baby I've ever seen, I think she was 23 weeks, I believe, but she was going to be in NICU for very long, but she was super tiny, all right? So you're extremely premature, you're less than 28 weeks, so a lot of things are not fully developed. I believe the eyes are still fused shut at this point, and that's why I gave you guys the Ballard when we went over it, because their skin is very translucent and transparent. You can see their veins and stuff, but when you're extremely premature, like less than 28, you're going to have super low birth weight. Then we've got very premature. Very premature is between 28 weeks to 31 and 6-7 weeks. So this is still pretty premature because you didn't get to bake as long in the oven with mama. So the thing is, you're still going to be pretty underdeveloped, and still have pretty low birth weight. And then you have premature, which is 32 to 33 and 6-7 weeks. Well, if you're premature, 32 weeks to 33 and 6-7 weeks, you're still doing better than extremely premature because at least you got to bake longer. Then you got late premature, 34 to 36 and 6-7 weeks. That's closer to full term. I mean, the closer we can get you to full term, the better, okay, and the more chances you have. And then we have different classifications of our birth weight, okay? So basically, when you're extremely low birth weight, that's going to be less than 1,000 grams. And that's our babies that are less than 28 weeks. And then you've got very low birth weight, that's 1,000 to 1,499 grams at birth. Then you've got low birth weight, that's 1,500 to 2,500 grams at birth. So the thing is, these are all things that's going to take a toll on the baby, because when you have low birth weight, then that also means you don't have the fat. Remember we talked about the brown adipose tissue? You have less of that, and so you're going to be more at chance for hypoglycemia, hypothermia issues, and then additional complications that you may have as well because of being low birth weight. And then we're going to be trying to get you to eat, but if you're if you're extremely premature, you're not going to be able to breast or bottle feed really. They'll have to do nasal OG tube feedings to try to get the food into your tummy. All right, so this is our premature assessment findings. So do you guys remember when I went over the Ballard exam with you guys last week? So we were able to go over different things on there. So I know I told you guys on one side, okay, if you're looking directly at it, so you got one side that's going to be your premature babies. On the opposite side, closer to the end, you're going to have more full term. So the thing is, looking at our... All right, can you guys hear me? I had to pause it for a second because I want to go get the Ballard worksheet that I gave you guys last week. So if you look at physical maturity, where it says -1 to 0, maybe even 2, that's going to be our preterm babies, and then maybe 2 to 5 or 3 to 5, that's going to be our full term. So just focusing on the physical maturity for preterm. So the skin is going to be kind of sticky, friable, transparent, red, translucent, and then lanugo, they're going to have anything from none to sparse. And I know some people had a hard time because they're like, well, it says none down here, but yeah, this is our preterm babies, very preterm, so they haven't developed it yet. Then they're going to have sparse and more abundant because, they're going to need it. And then your plantar surfaces, you're not going to have very many creases on the soles of the feet, but, you may have like maybe no crease, faint marks and stuff, and then they end up getting more and more. And then the breasts are going to be more like imperceptible, mainly flat with no bud. And then the eyes, they may be kind of fused shut if you're 26 or 28 weeks gestation. But like we were saying, the plantar creases, they're not really present before 28 to 30 weeks. And then their pinna, the cartilage, they have less cartilage prior to 34 weeks. So if you are trying to assess the pinna for the ears, you may kind of try to fold over the pinna, but it may stay folded, or there may be a very slow recoil. And then basically for little boys, the testes are going to be undescended, and then little girls, basically everything's going to be all opened up. You're going to have your labia minora, clitoris, all of that's going to be opened up. They may have a weaker cry. They may seem jittery. They may have diminished or absent reflexes. Their suck and swallow and breathing may be very, very immature at this point because they haven't finished developing. All right, I hope everything's going okay. I hope my voice isn't cutting out or anything, but I have my earbuds in. Like I said, I'm really trying to make this good for you guys. Can I get a ooh, ooh? That was weak. You guys owe me when we get to class and skills lab. All right, so these are going to be our common findings within our babies, especially the premature finding babies. We're going to have apnea, and like we said last week, the apnea we have periodic apnea, which is going to be less than 15 seconds. But basically in our preterm, we're going to see it in our preterm, and that's defined as cessation of breathing at less than 20 seconds. You may have bradycardia, where the heart rate's less than 100. You may hear the heart murmur, because the heart murmur is present related to the patent ductus arteriosus. Then we may see anemia, because due to all the frequent lab samplings, that's going to take away our erythropoietin. So we're going to see all of these different things, because these are just our findings for premature babies. So what does prematurity look like? So I'm pretty sure everybody's had a chance to see premature babies, especially if you had a NICU rotation, because NICU, they get a lot of babies that are preterm, premature. They get a lot of the super tiny babies. And see, these babies are kept in a special incubator, to where we have to really keep them safe. We have to keep them super safe in there. We have different types of incubators, but with babies that are super premature, we have them in one that's much stronger, that can give the baby what they need, because the baby's going to have thermoregulation, and they're going to have, basically nothing can replace mom's uterus or mom's womb, but it's going to be able to meet their complex needs. But this is what premature babies look like. They're super tiny. You can see how this baby, you can see veins, you can see how the skin is super, super tiny. You see how frail the babies look, just because they're still they're very much premature, so they didn't get a chance to grow like full-term babies. Okay, so medical management. The thing is, we want to make sure that we teach the parents everything they need to know, because to the mommies and daddies in here, I believe one of the worst things is just not knowing what's going on with your baby. Like when they don't tell you what's going on, they're just in and out, they're not teaching you, they're not telling you any updates. That's the worst, right? So basically, one of the best things you can do is keep the parents up to date on, what's going on, to teach them about the condition, the treatment, and follow up. And then lung maturity. So with preterm babies, a lot of times they have very immature lung functions. And even babies that are full term, sometimes their lungs aren't as mature either. But when you got your premature babies, their lung function is super immature. So we want to do that LS ratio, which is the leithogen sphingomyelin. I can't say that right, but basically this is going to be helpful, because this is what determines the lung maturity. So we have to keep an eye on the lung maturity and what's going on with that. And typically when they were still in utero, when they were antepartum, their mom took medications. The moms took betamethasone, or dexamethasone. These were steroids to help the baby's lungs. So these are considered corticosteroids, and they're given to women in preterm labor or preterm birth. And this is going to help accelerate the normal pattern of the lung birth. So typically, hopefully the mom was given that. We're going to want to monitor the baby's O2 saturation and blood gases. They're going to need all sorts of respiratory support. They're going to need to be on low flow nasal cannula, high flow nasal cannula, nasal continuous positive airway pressure, tracheal intubation. And it's all going to depend on the gestational age of the baby. But a lot of these babies that are super preterm, they're going to need respiratory support because their lungs are not mature to function as they should. So that's why you see a lot of the babies who are premature, you see them in NICU, they're all hooked up to different machines because they need help and support breathing. They're also going to have lots of lab tests, such as blood gases, blood glucose, because like we said, preterm babies, a lot of times hypothermia is an issue, and so is their glucose regulation. We're going to want to keep an eye on their liver function tests, CBCs. They may need blood transfusions, because that may be due to anemia. And like we said, these tiny babies, they have all these laboratory tests done, so that's taking away blood from them before they have time to get it replenished. They may have to get IV fluids for hydration. They may also need a central line placement, and then they may also have to have catheter of some sort put into the umbilical artery. And then they'll also be on medications such as dopamine. Dopamine is used for treatment of the hypertension, and also they're going to possibly need erythropoietin administration to help stimulate red blood cells. Opioids are going to help with pain that they may be dealing with, and then also surfactant. Surfactant is basically therapy for respiratory distress issues, but that's going to help, to help the lungs to function better. So what does it look like? Basically, this is the umbilical catheter. This is like one of those umbilical artery vein lines. And so what we use this for, this goes into the umbilical area like you can see on the picture, and then it's going to be threaded up into the main artery. So that way, that babies are able to get things that they need, okay? Because this is the thing, babies, you may not be able to get a good vein on babies that are super preterm because their veins may not be fully developed like they should. So we do use an umbilical artery line, and that's going to help to be able to put medications in or whatever is needed at this point or fluids, because like I said, they may not have good options for veins at this time because they're so tiny. Okay, so different nursing actions that we're going to do for our premature babies, okay? And like I said, if anyone has questions, please be sure to reach out and let me know. So, like I said, I want you guys to be sure to think about the why behind everything we're doing. Think about why, for instance. So, review prenatal and interpartum neonatal history for known risk factors. Why would we want to do that? Well, let's take a look at prenatal. Did mom have any STDs or anything? Did she have any diseases that we need to give her vaccines for? Did she have anything in her history, such as genetic issues or genetic diseases or complications with any of her systems in the organ? So did she have prenatal care? Because sometimes not having lack of prenatal care is going to cause infant problems for our infant. Then take a look at intrapartum. Did the baby have, for their fetal heart rates, was it a category 1, which is normal? Did we have category 3, which is really in danger? Was it a precipitous delivery? Was it a prolonged delivery? Was there any complications or anything? Did they have to use forceps? I mean, we want to think about anything that could have possibly happened intrapartum that could have been a complication. And then we also want to look at neonatal history. Since the baby's been here, what history have we had? Is baby having respiratory distress issues, low blood glucose issues? All of these things are going to tell us, what's going on, and it's going to be able to help with the nursing plan. Also, we're going to want to participate in any resuscitation procedure, because see, a lot of times preterm babies, NICU is going to be at the delivery, so that way they can help out with anything that they may need, like resuscitation, they may need to give the baby supplemental oxygenation. Baby may need, neonatal CPR, any of these things. So NICU is probably going to have to be at the delivery. And then NICU is also, they are present for all high-risk birth because they have the equipment and the knowledge to be able to help the baby and give the baby what they need. And then once the baby is stabilized, then baby's taken to NICU, because you don't want to take the baby to mom-baby couple of care because they don't have what they need there. So they're going to have to go to NICU for ongoing support. Also, it says to perform gestational age assessments. I think they do that in the NICU, but they don't typically do it on couple of care. That's something we can find out. And then they'll also need to perform physical assessments. So that way we can kind of see what's going on, see if there's any other areas of concern that we need to be aware of. Okay, also we want to provide respiratory support, because this is the thing. Remember that babies have super immature lung function, especially our preterm baby, because baby didn't get to develop as long as they should have been able to. And also remember your ABCs, airway, breathing, circulation. So maintaining a patent airway is going to be the most important, because if the baby can't breathe, is anything else important? No, because you have to breathe to live, right? So think about your why, because if you can understand why we do these things and what we're looking for, that's really going to make sense. So, suction the airway to remove secretions. Why do we do this? Well, a lot of times babies may have, amniotic fluid, or baby may have saliva or whatever that is stuck in the airway. We have to suction that out in order to help maintain a patent airway. Now, what happens if baby has secretions in the lung area, but we don't do anything, we just administer oxygen. That's not going to do any good because the secretions is blocking the airway. So this is why you want to think about why are we doing this. So remember your airway breathing circulation, maintain a patent airway. Then we need to suction the airway to remove any secretions, to get any blockage out, to stop them from breathing. We need to clear all of that out. And then we also want to administer oxygen as necessary. They may need high flow oxygen, they may need a CPAP, but they may even have to be on a ventilation. But like I said, now that we have a patent airway, we've removed any suction, we've suctioned anything out, now we want to provide oxygenation to get in to oxygenate the different organs and stuff. We want to assess cardiovascular, the color. What can color tell us? If baby's blue, acro, pale, parla, gray, acrocyanosis is okay, but all the rest is a no-go. So we want to assess the color. The heart rate, what's going on with the heart rate? We said that if baby's having a lot of apnea issues, they may end up having bradycardia, so we want to take a look at the heart rate. We want to look at the blood pressure because we said sometimes preterm babies sometimes have hypotension, so we want to monitor that. Our murmurs, remember the PDA, patent ductus arteriosus, sometimes that hasn't closed yet, so they're going to have a murmur. What is their pulses like? Are the pulses bounding? Are they thready, weak? Cap refill, do they have a normal cap refill or a slow cap refill? We want to monitor H&H. We need to give blood if needed because, like we said, they're going to be having to take all sorts of blood samples. So the babies don't have enough time to replenish that, so they may need a transfusion. And then we always want to go back to reassess the interventions. We want to reassess the response to the interventions to see if they worked. So don't just do the interventions and then not assess the response, because that's not going to be helpful. We need to know, did the response work? If not, we need to move to something else. So I do hope you're all doing okay. I know that this is a lot of information already and we're just getting started, but remember, we got this and we're all in this together. It's time to have a sing-along. We're all in this together. Go ahead and start singing for me. Okay, I'm probably getting side-eye, but that's okay. I still love you guys anyway. All right. So now we're going to talk about maintaining fluid and electrolyte balances, okay? So this is some things we're going to take a look at. And like I said, we want to look at, what do we want to look at? We want to look at the why behind all of this. So it's like, why are we doing this? What are we looking for? We want to make sure that baby is hydrated and is getting what they need from here. So we want to monitor the eyes and nose. Intake and output. Why? Well, do we have adequate output? Do we have adequate input? Because they may not be able to actually breastfeed or bottle feed at the moment, so they may have an OG tube or an NG tube, but we want to make sure. We want to monitor how much we put in, and we want to monitor what's coming out. We also want to weigh diapers because that's going to help us to determine the output. We also want to assess the frequency, color, amount of urine to determine the hydration of the babies. We want to do a good job of recording the fluids from I's and O's from every single thing, from feedings, chest tubes, urinary catheters, blood draw. We want to keep track of all of that. We also want to monitor potassium and sodium levels because, see, potassium, that has a lot to do with the heart. Now, we may also need to do some restrictions because basically BPD is bronchopulmonary dysplasia, which is a respiratory issue. So babies who have issues with BPD and PDA, which are your patent ductus arteriosus, they may have complications that can lead to pulmonary edema. So this is why we may need to end up doing fluid restrictions, because if that's the case, we don't want to have pulmonary edema issues or anything like that. So this is kind of why we'd have to put restrictions in if needed. So like I said, you want to think about the why. Why are we doing what we do? Okay, we also want to administer IV fluids as ordered, and we also want to assess the IV sites as well, because we just kind of want to make sure that we are not going to put the baby in fluid overload. With these fluids, we have to run them super slow. And we know that the medications, fluid, everything we do is weight-based. So, we want to keep an eye on all of that. And like I said, with electrolytes, we want to monitor hyperkalemia, hyponatremia. We want to monitor all of these things. And like I said, with administering IV fluids, we want to look at the side, assess hourly for signs of infection, skin breakdown, because the thing is, babies they can have all sorts of issues with skin breakdown just because they're so new, and they don't have the defense mechanisms that we have. So we want to keep an eye on all of that, We want to monitor the glucose because, like we said, babies that are preterm, they have a lot of issues with hypoglycemia. And with hypoglycemia, you can also have hyperthermia. Parental nutrition. The babies may not be able to actually feed. They may not be able to breast or bottle feed because we worry about aspiration due to their system, their stomach and GI system being immature. So babies that are less than 32 weeks and low birth weights, we may need to do like an OG tube or NG tube or gastric lavage feeding or something like that, so we may have to give maternal nutrition. If they're unable to tolerate the gastric feeds or feeding with a bottle or breastfeeding, then we may have to end up giving them paternal feeding. We also want to make sure we pay attention to any milk that they're getting, because human milk or donor milk, that can cause necrotizing enteric colitis. That is an issue with the GI, and we're going to talk about that later. So we want to kind of keep an eye on the feeds as ordered, because like I said, that could also cause problems. We also want to make sure that human milk needs, they're getting their calories, they're getting their irons, whatever they end up needing. The moms who want to breastfeed, we want to get them pumping as soon as possible, because even if we only get 1 or 2 drops of colostrum, then we can take that down to NICU and they can mix it with their feeds and still give it to them, because then they're still able to get some vitamins and nutrients. We want to administer gavage feedings per order. Okay, so sorry about that. All right, so what we were talking about was the gavage feeding orders. So we want to assess first we want to assess the orders, and then when we do the feeding, we want to look for feeding intolerance, such as bloody emesis, bloody stools, apnea, bradycardia, abdominal distension. And I know that's a lot, but like I said, we have to think about, how this is going to affect the baby, especially when they have all these other issues. Also, we want to monitor the weight daily, because we want to make sure that they're not losing, but gaining. So this is all stuff we're going to need to document with our preterm babies. And we also want to monitor their head circumference and length weekly. Why do you think we want to do that? We mainly want to do that because we want to make sure that they're progressing well, because like I said, they're already preterm, so we want to make sure that they are growing, they are gaining weight. We want to make sure they're not going backwards. All right. So transitioning neonate from gavage feedings to oral feeding, because like I said, depending on the needs of the baby and depending on how preterm the baby is, we would make they're probably going to be on gavage feedings, and that's feedings from, having the NG tube and the OG tube, basically. So once they get to a certain level of care, once they get to a certain point, they can transfer over to oral feedings with breast or bottle feeding. So these are some things we're going to try to get them transferred over to. We want to make sure they have cardiorespiratory regulation, because at this point, when they're getting older, when they're starting to kind of get older, then their cardiorespiratory system should be starting to mature, so hopefully things can regulate with that. Also, we want to make sure the baby is able to demonstrate a coordinated suck, swallow, and breathe reflex, because this is a thing. Babies have to learn how to eat, because when babies were set inside of mom, baby got everything they needed from the placenta. So being outside and being a preterm baby, they may not have been able to eat, so that we had to put the tube down their nose or their mouth. So they're still not doing anything, they're just having the food put into their mouth or into their stomach. Now, having to breast or bottle feed, they've got to learn how to suck, swallow, breathe, all at the same time. And then also we want to make sure the baby has a good gag reflex 34 weeks gestation, because at this point, at least, they're able to gag, whereas they may not be able to gag before that. So they're going to silently aspirate, which we don't need that. We also hope that at this point they're going to start to demonstrate hunger cues. Like we said last week, hunger cues is letting us know that baby's hungry and ready to start eating. So sucking on their hand, trying to eat the blanket, rooting, looking around for mom's breast, all of those are hunger cues. And we said crying is a late cue. Also position infant in the paced feeding position. You want to properly position the neonate for bottle feeding by holding the infant like, kind of side lying and sitting upright, because you don't want a bottle prop and the bottle needs to be lower than the baby actually. But yeah, so you want to have baby in a good position for feeding. And you also want to observe baby while they're eating. Are they having cyanosis issues? Are they having apnea issues? So you're looking for respiratory distress with feeding tolerance, because sometimes when babies are feeding, sometimes they do start to turn blue. Sometimes their heart rate goes down, so they may be struggling. So these are things that we need to keep an eye out for. You also want to provide breastfeeding support for moms who want to breastfeed, and then you also want to give medications as ordered. Skincare. So that's also another huge one with the baby, basically. So skincare is, we want to keep a close eye on baby's skin, and we're going to assess overall conditions with the Braden scale. The Braden scale is on page 553, and I believe that's on my notes. The Braden scale is going to be a little bit later, but we can go ahead and talk about it now. Not sure where it is. Yeah, Braden scale isn't until slide 20, but we can still go ahead and talk about it now. So we want to just kind of keep an eye on the baby's skin, because the baby's skin is so fragile at this point. The baby's skin, we want to make sure that we protect it and keep the baby's skin super safe. So something you're going to want to know is you're going to want to use adhesives sparingly, because adhesives, we just don't, those can cause skin breakdown. So you want to assess the overall skin condition by using the Braden scale. And also we want to prevent, pressure-related injuries. So we want to be super careful when we're using adhesive removals or avoid removers or solvent, because that is going to not be good for the baby's skin. We want to change diapers frequently, because if you let babies sit in their stool for too long, what can happen is it can cause their bottom to break down and get diaper rash and start to bleed. You want to do changing of positions every 4 hours. So this is why we have cares. We do cares so that way we can change the baby's position, make sure baby, because if you let baby be in position for too long, that's going to cause pressure ulcers, which we do not need at this stage in their life. Also, we want to use hydrocolloid products as protective layers under the medical devices, get them labs as ordered, assess for signs and symptoms of jaundice. And then for the pain, for pain, we want to give sucrose with the pacifier. Sometimes they can breastfeed, if they have a good breastfeeding, then they can breastfeed while you're getting their, certain labs and stuff. But baby has to have a super strong latch, and mom and baby have to have a really good breastfeeding, because if they're not good at breastfeeding, then all baby's going to do is cry and kick at you while you're trying to do the heel stick. You want to give opioids as needed, and also non-pharmacological. Swaddling is good, swallow the baby nice, because if baby's comfortable, then, that's going to help them, also help them with the pain as well. Kangaroo care, which is skin to skin, therapeutic touch, such as inviting parents to comfort their baby by stroking their head or by stroking their hand, decreasing the environmental stimuli, because that's going to cause a lot less stress and make it more calm. And you also want to evaluate the effectiveness of this. And please, if anyone has any questions, please let me know. I hope my voice isn't cutting out. I hope not. I really hope it isn't. Okay, so we want to give appropriate developmental care. We want to maintain a quiet setting for the baby, because when you have a quiet setting for the baby, it's going to be very calming, But if you have a loud, lots of stimulation, it's just going to upset the baby and cause them to be more upset, and it's going to cause them to cry. So like we were saying, you want to have a quiet setting. We want to make sure we kind of have, we have like low stimuli, keep the lighting super dim. We want to cluster nursing care. So this is why in the NICU they do these cares, which they come in, they change the diaper, they feed baby, they try to do all sorts of things all at once, so that way the baby can have time to rest. Because the more time the baby can rest, then that's going to really help with healing. and growing. Also avoid clustering painful interventions because the thing is, if you put all these painful interventions together, then baby's going to have all sorts of pain issues, and that's just going to be very upsetting, and it's going to be really hard to get the baby to calm down if you do all sorts of painful things at once. So you want to try to kind of spread those out, you know. Also, we want to give them individualized care because every baby's different, you know, so just try to give them care based on their need, basically. You want to provide breaks in between care, you know, minimize handling the neonate. I mean, we have to, I mean, babies that are unstable, like I know that you guys have been in NICU, and then like there's been babies that you couldn't hold because those babies aren't stable. So you go in and do your cares with them, but you just kind of let them be just because they need time to rest. So that way they can grow and be strong. You want to position and swaddle slowly and gently, 2 to 3 hours. Prone and side lying, that helps with oxygenation. Swaddle in a flex position and create a baby's nest. I don't know if you guys are familiar with a nest, but basically this is inside of incubators and even in cribs as well. I mean, you take some blankets and you roll them, and then you just kind of put them in a circle. Then you put the baby in between, all wrapped up in a blanket, and we call that nesting because that kind of reminds the baby of what it was like to be inside of mom, just to kind of be all snuggled together and nested together. It's super cute. Okay, so these are some continued actions for preterm neonates. We want to encourage kangaroo care. In my baby, we used to have a saying, when you don't know what to do, kangaroo. That means skin to skin, because if anything, that's going to help calm the baby down. We also want to provide emotional support to parents and family, because the thing is, you know, they feel at a loss. They feel like there's not much they can do when there's plenty they can do by just being there for the baby, but they just kind of feel that they're at a loss. So this is why educating them and just being supportive and letting them voice their fears and cares, you know, that helps them because that lets them know somebody cares. And also involve the parents and family, you know, let them come help out. You know, parents get so excited the first time they get to give a baby bath. They get so excited the first time they get to change a diaper. They get so excited the very first time they get a chance to actually do an outfit change on the baby. These are things that most people take for granted, but you know, parents of NICU babies and premature babies, they don't get that opportunity just because they don't get to be with the baby 24/7. Okay, so that was prematurity. So if you have any questions, please let me know, okay? So now we're going to change focus and go to signs of respiratory distress, which we already talked about this last week. So this should be a review. So this is on page 554, if you're following along. I hope you guys are okay. Remember, we're all in this together. Okay, so who can tell me what are the signs of respiratory distress? I don't see any hands. If you don't answer this question, you're wrong and canceled. And when I'm asking you guys questions, try to answer at home, okay, please? That makes it more interesting for all of us. So respiratory distress is a life-threatening lung disorder that results from small, underdeveloped alveoli and surfactant-like levels of pulmonary surfactant. So a lot of things you're going to see in the baby for respiratory distress are audible expiratory grunting. I tried to do the grunting in class, but you guys wanted a video example, so I guess my grunting wasn't good enough. But guess what? I'm going to do it now. So that's kind of an example. It's not as good as the video, but basically when baby is making these expiratory grunting, parents think it's singing. It's not singing, it's grunting, and baby's in respiratory distress, so baby's trying to compensate. Also nasal flaring. We saw the video, and basically the nasal just kind of flared out. And retracting is when baby is breathing, but it's more of a sunken appearance to where you can see the ribs and the rib cage. Also, you may see duskiness or cyanosis. So that cyanosis is blueness. Duskiness is more grayness, basically. And then tachypnea. Rapid breathing. So these are all signs of respiratory distress, and what the body's trying to do is the body's trying to compensate because the baby can't breathe. But if you keep doing this for too long, then baby's going to eventually poop out and tank. So make sure you know your signs and symptoms of respiratory distress, because you are going to have to know that, okay? Maintaining neurothermal environment. So these are basically things that we're going to end up doing to help the baby stay nice and warm, because the thing is, we want baby to we want them to be able to be comfortable at their body temperature. So premature neonates, they're unable to protect themselves against fluctuations in the environment due to being immature and then having the low stored subcutaneous brown fat. So we need to do interventions that's going to support maintenance of, being able to have neurothermal environment to prevent development of cold stress, because cold stress is what we worry about, because cold stress can lead to all sorts of problems for the baby. And I know we talked about this last week. So some things we're going to want to do is rapidly dry the infant after birth, because if we let the baby stay cold and wet, then cold stress is going to happen. We are going to want to pre-warm all of our supplies, pre-warm those supplies, because even anything that touches the baby that's cold can cause cold stress. If they have to be in the warmer, we want to make sure that we have them have the warmer already set for the baby. Encourage skin to skin. And also, just different interventions that's going to help the baby to stay nice and warm. Because if we can prevent cold stress, that's going to prevent a lot of complications. Okay, and then this is the lovely Braden scale that we were talking about earlier. So like we said, babies, they are more at risk to have pressure ulcers and skin integrity issues just because they're so young and so new, and their skin is still pretty mature. So I'm pretty sure you guys had a chance to use the Braden scale when you guys were in, when you did med-surg and fundamentals. So basically, the higher the score, the better that the person's going to be. But when you're mobile, when you're nice and mobile, you can move around and stuff, whereas babies can't really move around like that. So they're pretty much immobile. They're going to be very limited there. So basically, this Braden score sheet, this is going to pretty much help with, giving us a good score. So if you are greater than 13, that's going to be equal to, you're going to be more at risk. So actually, sorry, I meant the higher the score, the worse off you are. So like if you have no limitations with no mobility, that's a 0. No sensory issues, that's a 0. No issues with friction and sheerness, that's a 0. So the higher the score, the more problems you have. So basically, this is the Braden score that we use with our babies. But like I said, this is kind of why we have to keep an extra eye on them, because babies are immobile. They can't get up and walk around. They can't change their bed around so it's not as sheared frictiony. We have to do those things, so we have to kind of keep a special eye on the baby. Okay, so back to respiratory distress syndrome. Okay, back to respiratory distress syndrome. All right, so like we were saying, that this results from small underdeveloped alveoli and insufficient surfactant levels that result in atelectasis. Atelectasis is collapsed lung. Okay, so like we were saying, that babies, they do have a lot of issues with breathing just because their lungs are immature due to fetal lung immaturity. So different things we're going to see is we're going to see hypoxemia, hypercapnia. Yeah, we have hypoxemia. We have pulmonary artery vasoconstriction. We have the right to left shunting through the ductus arteriosus. We have metabolic acidosis due to the buildup of lactic acid that results from prolonged periods of hypoxemia. We also have respiratory acidosis that occurs from collapsed lung, collapsed alveoli, and being unable to rid the body of excess carbon dioxide. So the test that we use to evaluate lung maturity is that lovely PG, which stands for, I think it's, and I cannot say this word, I'm not even going to be able, I can't say it because I keep messing it up, but it's kind of like fasol something. And then, so PG is synthesized from mature lung alveoli and is present in the amniotic fluid within 2 to 6 weeks of a full-term baby. So the presence of PG indicates lung maturity, and the decrease in this indicates the risk for respiratory distress syndrome. And the LS is the lithic spiromyelin. I'm saying that all wrong, but these are 2 phospholipids that are detected in the amniotic fluid. The ratio between the 2 phospholipids provides information on the level of surfactant. An LS ratio greater than 2 to 1 in a non-diabetic woman indicates the fetus's lungs are mature. An LS ratio of 3 to 3 to 1 in a diabetic woman indicates fetal lungs are mature. All right, so let me say that again. So the LS ratio greater than 2 to 1 in a non-diabetic woman indicates that the fetus's lungs are mature, and LS ratio of 3 to 1 in a diabetic woman indicates a fetus lungs are mature. Now, I just kind of wanted to just tell you what the tests are. It's a nice to know, but not a need to know. But I just wanted you guys to understand how we evaluate the infant's lungs maturity. Oh, and the PG is phosphatidylglycerol, which I'm sure I'm saying it wrong. All right, so these are all complications of respiratory distress syndromes. Because the thing about the PDA, everybody has a PDA, but the problem is if it stays open for too long, that can lead to cardiac issues. Then they can also have pneumothorax, they can have bronchopulmonary dysplasia, pulmonary edema issues, hypotension, anemia, oliguria, hypoglycemia, ROP, which is retinopathy of prematurity, and we're going to talk about that later. Seizures, we're also going to talk about intravascular hemorrhage. So all of these things can lead to complications of from respiratory distress syndrome. All of these different things, complications. All right, so these are going to be our assessment findings, okay? So you definitely want to know your assessment findings of respiratory distress syndrome. So these are things that you definitely need to know, okay? So basically, this varies on the gestational age. Also, a lot of times they may have issues shortly after or immediately after their delivery. They may have issues with tachypnea. Also, they may have retractions, audible grunting, nasal flaring. They may have gray or cyanosis skin color. Breath sounds are decreased. They may have crackles, lethargy, acidosis. So you are going to want to know your assessment findings. And you're also going to need to know your labs, okay? So basically, they may have increased oxygenation requirements to maintain the PaO2 and PaCO2. So you want to know your normals. So basically, the normal range of PaO2 is 60 to 70. The normal range of PaCO2 is 35 to 45. So you want to know your normals. So let's say we have a PaCO2 of 50, then that's abnormal. So you do want to make sure you know your normals versus abnormals for your lab functions, okay? Lab functions for respiratory. Okay, so these are some things that we're going to want to do for our babies, okay? So this is how we're going to need to manage this. Okay, so we've got cardiorespiratory. We want to look at O2 sats and blood gases. So these babies are going to need to be on the monitor so we can kind of see what's going on. So cardiorespiratory, oxygen saturation, and blood gas monitoring, we need to keep an eye on these things so that way we can kind of see, you know, what the abnormals are, okay? Because the baby could be sitting at maybe 98, but then 5 minutes later can be down in the 80s, all right? And then exogenous surfactant as indicated for neonates at risk for respiratory distress syndrome. So you do want to make sure you know your medical management. Also, respiratory support such as CPAP, ventilation, endotracheal, also chest x-rays because we want to see is there anything going on. I mean, we want to take a look in there and see what's going on. Lab tests such as arterial, venous, or capillary blood gases, medications such as antibiotics is indicated. So make sure you know your respiratory medical management for respiratory distress. Okay, surfactant replacement. So surfactant is what we were going to want to give, you know, for our patients dealing with respiratory distress syndrome. So what we give is this acts by reducing the surface tension of the alveoli and preventing collapse during expiration. So this is prophylactics. It's initiated within 15 minutes of birth based on the risk factors of respiratory distress syndrome, such as gestational age less than 27 to 30 weeks, especially if mom did not receive antenatal steroids. So this is rescue treatment. Treatment is confirmed. Treatment of confirmed respiratory distress syndrome and is initiated within 6 hours. So you do want to make sure you know this. Make sure you know that we give this as a replacement therapy, because this is going to help enhance lung compliance and improve overall oxygenation. It's typically given endotracheal or thin catheter or mask. And then your side effects are going to be bradycardia, decreased oxygen O2 desats, tachycardia, reflux, of gagging, cyanosis. So these are things that we're going to want to give to kind of help with the lung function, basically. And it's going to help to make breathing easier, basically. We want to make sure it's going to help enhance compliance to allow easier inflation, which decreases the work of breathing and improves overall oxygenation of the infant. All right, so these are some nursing actions that we're going to want to do for respiratory distress syndrome, because respiratory distress syndrome is pretty big in our babies. So this is why we're spending so much time talking about it. So remember your priority. Remember airway breathing circulation. Maintain a patent airway. That's why it's first, okay? Because if the baby can't breathe, then why are we even bothering to do anything at all? We want to assess placement of endotracheal tube. We want to make sure we assess placement of that to make sure it's in the right area. Also listen for equal breath sounds, chest rise, CO2 detector, administer oxygenation as ordered, maintain NTE, which is your neurothermal environment. Suction is needed, but when you suction, this may cause bradycardia, it may cause hypoxemia or bronchospasm. So this is why we suction, but we don't want to suction all the time because it can cause all these problems. We want to keep an eye on those vital signs, monitor eyes and nose, and promote rest, because resting is very helpful, in repairing and healing. So like I said, definitely don't forget your airway breathing circulation, and maintaining a patent airway, because that's always going to be the priority, because like we've said, if the baby can't breathe, then what's the point of doing any of this? Okay, so that's your respiratory distress syndrome. So we have gone over preterm, we've gone over respiratory distress. So, if you have any questions, please feel free to reach out to me, and I'll be more than happy to help you, because I know video lectures, online PowerPoints, but like I said, I'm here to answer any questions you may have. Okay, and the nice thing about this being a video or either an online, you can pause it anytime you need a break. So next we're going to go ahead and talk about the patent ductus arteriosus. This is on page 558. So this occurs when the ductus arteriosus remains open after birth. Guys, remember, when baby is still connected to the placenta, they're getting everything through their mom, but yet the whole cardiac system is kind of wired differently. So after birth, that PDA stays open, but the thing is, with time it's supposed to close. But like I said, if it stays open, then that's going to cause all sorts of complications. And like I said, this is on page 558. So different complications are congestive heart failure, chronic lung disease, renal insufficiency, feeding intolerance. NEC is necrotizing enteric colitis, and IVH is ventricular hemorrhage. So these are some things that can be caused by patent ductus arteriosus. So this is kind of why we want to, kind of keep an eye on this. And you can kind of see on the picture, you can see the hole that's still open, and so blood is not going where it's supposed to be going here. Okay, assessment findings. So basically we said that we're going to have the heart murmur, and that's going to be heard at the upper left sternum. And some neonates with PDA, they may not have an audible murmur, but some do have a loud murmur, basically. They're going to have an active precordium, that's visible movement of the heart contracting on the patient's left chest. They're going to have bounding pulses, widening pulse pressure with decreased diastolic blood pressure. They're going to have tachycardia, tachypnea. They're going to have recurrent apnea, increased worker breathing, increased demand for O2 or ventilation, difficulty weaning from vent. PDA is going to be present in the echocardiogram. And also they're going to be doing like a chest x-ray. They're going to need to do a chest x-ray because this may show prominence of the left atrium, and also the left ventricle and ascending aorta, as well as increased pulmonary vascular markings. So you do want to make sure you know your assessment findings, okay? Because one of the big giveaways for this is going to be the heart murmur. but like we said, not all babies have them, but that is typically a classic sign. Diagnostic tests. So some things that we're going to want to do, like we said, we're going to have to do an echo because the echocardiogram is going to confirm it. Also fluid restrictions, less than 130 milliliters kilograms per day, because like we said, we do kind of worry about maybe pulmonary edema, so they may need to have a fluid restriction. Diuretics, such as medications like diuretics, indomethacin and ibuprofen when indicated, but your indomethacin and ibuprofen, these medications were frequently used in the past, but they may not be used today due to side effects such as GI bleeding and decreased glomerular filtration and decreased urine output. Cardiac consult, this is going to determine treatment method and need for surgical intervention. And then we may have to do something called surgical litigation. Sometimes it's called suture clip or coil of the PDA. It's indicated for neonates with a hemodynamically significant PDA who do not respond well to medical management. So we may have to go in and do a surgical litigation where we just kind of go in and try to clip it or suture it together and sew it up basically. All right, so nursing actions. So pretty much it's going to be similar to what we do for preterms. We're going to make sure that we give them, respiratory supportive care such as oxygenation, mechanical ventilation, medications as ordered. Yeah, we're going to give medications, whatever's ordered for the baby. We're also going to keep an eye on I's and O's and monitor for fluid overload because, like we said earlier, they may be at risk for pulmonary edema. Fluids may be restricted until PDA is resolved, and then they may be NPO during treatment and possible surgery. And prepare the neonate and family for surgery if we have to end up doing something for surgery, like have to go in and kind of physically close the heart up. All right, so that is your PDA. So let me know if you have any questions. Okay, so intravascular hemorrhage. So this is also something that we're going to be looking at for our babies. Now, there are different types of grades for this. But basically, this occurs in the germal matrix tissue surrounding the lateral ventricular of developing the brain, and it occurs primarily among premature, very low birth weight neonates and affects 40 to 60% of infants. Okay, so there are 4 grades in here of intraventricular hemorrhage, and it's based on the extent of involvement. The higher the grade, the more severe the hemorrhage, and the higher the grade, the long-term sequelae for this basically. But this typically occurs in babies that are premature and very low birth weight neonates. So these are your different types of grades for this. So for grade 1, you're going to have hemorrhaging in the germal matrix. Grade 2, intravascular hemorrhage without ventricular dilation. Grade 3 is intraventricular hemorrhage with ventricular dilation, clots fill more than 50% of the ventricle. And grade 4, extension of blood into cerebral tissue or parenchyma involvement. All right. So looking at the picture, you can see, how each area looks affected, because in the first one, in grade 1, you can kind of see what's going on, with the different types of the hemorrhage basically, because like we said, the grade 1, this is hemorrhage in the germal matrix, and in grade 2, we got it's going to be with ventricular dilation. The clots are going to, this is going to be, grade 2 is in ventricular hemorrhage without ventricular dilation. So dilations are not quite occurring. And then grade 3, we're going to have ventricular dilation. The clots are going to fill more than 50%. So you can kind of see how the clots are getting bigger. And then grade 4, basically extension of blood in the cerebral tissue or the parenchyma. So you can kind of see how things are continuing to increase here. Okay, so our different risk factors that we're going to see with this. Our risk factors, we said prematurity, We said prematurity. We also have low birth weight, parental asphyxia or birth trauma, because see, sometimes babies have a traumatic birth, and that can cause this as well. We have respiratory depression with ventilatory support, volume extension, rapid administer of sodium bicarbonate. If they have a low birth 5-minute outburst score, alterations of blood pressure, acidosis, low hematocrit, pneumothorax, and litigation of PDA. So long-term prognosis often depends on the severity of the hemorrhage, with death rate of 5% for small hemorrhage and 10% for moderate hemorrhage and 50% for severe hemorrhage. So, and then also sometimes neurological problems such as cerebral palsy or delayed mental development can cause 10% of the neonates with the small hemorrhage. So that's also something to keep in mind. But like we were saying, this is something that typically, you may see as a complication. And like we were saying, neurological problems can occur 10% of cases with small hemorrhage and 40% with moderate hemorrhage, cerebral palsy, or developmentally delayed development. So this is something that is not, this is complications that can cause all sorts of problems for the baby and the family too. Okay, so these are going to be our assessment findings. You may see a sudden deterioration in their condition. And like we said, like babies, they can't be like, hey, mommy, I don't feel good. Mommy, I'm tired. Mommy, I can't breathe. You have to kind of keep an eye on their condition. We've got oxygen desats, bradycardia, hypotonia. Like we had said earlier, hypotonia is low muscle tone. And then we may see metabolic acidosis. We may see shock. We may see a significant decrease in hematocrit because they're having the hemorrhage. And then we may also see full or tense anterior fontanelle because the thing is, this is, we're having a hemorrhage here, so you may see like a full or that it may be tense of the anterior fontanelle actually. And then we may end up seeing hyperglycemia. So these are some different things that we're going to end up seeing. Okay, signs that this is getting worse is going to be apnea, increased ventilatory support. We may see seizure. We may see full tense fontanelles, diminished activity, or level of conscious. So a lot of times when they say diminished activity, you know how babies are typically moving around, they're looking around, and then they may become more lethargic. They may not be, so these are signs that you have to look for in a baby because like I said, they can't really talk and tell you what's going on. Okay, next is going to be our medical treatment, okay? So we're going to take a look at our diagnostic tests that go with this. So we're going to do cranial ultrasounds within the first week of life because we need to see, can we see the hemorrhage already? That's going to show us, this is going to be able to help us to be able to assess for intravascular hemorrhage. Also lumbar puncture. We're going to want to do a lumbar puncture. And this is going to help us in evaluating of intravascular hemorrhage. We're going to want to look at the cerebral spinal fluid. That's going to be analyzed for red blood cells. Also increased protein concentration. So these are things we're going to want to look at. We're also going to want to take a look at lab tests like hemoglobin and hematocrit because it's probably going to be lower due to the hemorrhage, and they may need a blood transfusion due to the hemorrhage. So you do want to make sure that you know your diagnostic test for this. Like I said, we have to know how to look for this. So make sure you know your diagnostic tests such as your lumbar puncture, cranial ultrasound, lab tests, and blood transfusions. So you do want to know your medical management for this diagnostic test. Okay, nursing actions. So you do want to make sure you know your interventions for this as well. So we're going to want to assess for change the level of consciousness. They may not be moving around as much. They may not be as active. They may just be more lethargic and hypotonic. We want to keep an eye on those vital signs, look at their behavior. So we want to assess for all of these different things. We also want to reduce stress because anytime they're stressed, that's going to cause stimulation, and the more they stimulate, the more they're going to hemorrhage. Also administer fluid volume replacement slowly because you don't want to do it too fast because that can end up causing a shift of fluids. We want to reduce shift in cerebral perfusion, such as ensuring midline head positioning. So we kind of just want to have the head midline. We don't want the head flopped over because that's going to end up causing more problems with the hemorrhage. Keep the head of the bed flat or slightly elevated because we don't want to. We're trying to reduce the shift in cerebral perfusion, and so you want to try to keep the head of the bed either flat or slightly elevated. You want to keep the hips below head levels with diaper changes, maintain temperature. You want to minimize crying because if baby's crying, that's going to cause more issues that could cause more hemorrhage, and also minimize environmental stimuli because if you don't minimize environmental stimuli, that's going to end up causing more stress. So you want to make sure you know your interventions for this as well. Okay. Necrotizing enteric colitis, NEC. All right, so this is on page 560 if you're following along with me in the book. So what this is, it's an acquired gastrointestinal disease and most common gastrointestinal emergency among neonates. So this is characterized by the inflammation of necrosis of bowel developed after the initiation of enteral feeding in preterm. So this is why we kind of have to keep an eye on our preterm babies because like I said, we're doing a lot of those gavage feedings, really, enteral feedings, and this can cause an inflammation. It can cause an inflammation in the bowel if we're not careful, so we really have to monitor them. With risk factors, we're going to see decreased immunological factors in the GI tract, increased gastric pH, immature intestinal barrier, decreased intestinal mortality, prolonged range of motion with amniitis, birth asphyxia. You may see babies who are SGA because babies who are smaller, they're going to have more weaker systems and may not be able to handle all of this. You may see risk factors of congenital heart disease, anemia, and formula feeding baby. They say breastfeeding significantly reduces the risk, so you may see this in bottle feeding babies. Okay, so this typically is going to begin 3 to 10 days after birth. So, and it can also occur up to several weeks of age. So this is something that we would just have to keep monitoring for. Different assessment findings, and you want to make sure you know your assessment findings for this as well. We may see lethargy. This is why we got to keep an eye on the baby's level of consciousness and the baby's behavior. We may see apnea and bradycardia. We may see blood in stool, occult or frank, temperature instability, hypotension and shock, diminished urinary output, abdominal distension. We may see tenderness, bilious Rubin. Does anybody know what bilious Rubin is? Bilious vomiting. What is bilious vomiting? Anybody got their hand up? I see you. Yeah, I'm trying to make you laugh. I don't think I'm making you laugh, but I'm trying. But bilious vomiting, that's pretty much bile in the vomit. So if you see like vomit that's like a greenish but bilious color, that's what bilious vomiting is. They may have increased gastric residual, discoloration of the abdomen, and visible bowel loops. At the abdominal x-ray of films of neonates with NEC may show diffuse distension of the intestines with gas in one part of the intestines and lack of gas in other parts, air in the wall of the intestines and portal venous system, dilated loops of the bowel, and air in the abdomen. So you do want to make sure that you know your assessment findings for this. Okay, so for this, we also have our medical management for this. So for our diagnostic test, we're going to need to do an x-ray. And like I said, think about your why behind it. So we'll do an abdominal x-ray just so we can go in and look to see if anything looks abnormal. Also lab tests, we want to do blood cultures, CBC, stool cultures, electrolyte panel, coagulation, medications. We want to make sure we're given antibiotics because of the inflammation, analgesics for pain, antihypertensives. That's going to help to, help with. Well, we want to give antihypertensives if needed, because see, everybody may not need antihypertension because a lot of times this causes hypotension. Also, we're going to want to have them on NPO status because the bowel area is already inflamed, so they're going to need to be NPO. We're going to want to give IV fluids just so that way they don't end up getting dehydrated, and then gastric compression. So gastric decompression, that's a way of removing gas and fluid from the digestive tract to relieve pressure and symptoms of obstruction. Doctors will usually insert a tube through the stomach and nose. Doctors will usually insert a tube through the nose and into the stomach, and that's going to kind of help to decompress the bowel system to kind of release some of that gas and fluid. Okay, if we have to end up doing surgery, then these are the different types of surgeries that we're going to need to do for this. So basically, we're going to do removal of the necrotic bowel or perforation of the bowel, and also temporary colonoscopy may be performed because we may just need to give the bowel area a break, but it would be temporary. They can go in and fix it and change it back to where they don't have the colonoscopy. But like I said, in some cases, they may have to end up removing the necrotic bowel or perforated bowel. So these are some things that we may actually have to end up doing, you know. So yeah, this is surgical management, but like I said, with these, we just kind of want to make sure they're hydrated, make sure that we're, you know, taking care of them and answering any questions the family may have. Okay, nursing actions for this. So we want to assess for abdominal distension because we did say that was an assessment finding. Like I said, you want to know the why behind it. Assess for visible bowel loops, emesis, bloody stools, abnormal vital signs. We want to withhold feedings and obtain IV access to give them IV fluids because, like I said, withhold the feedings because the thing is your bowel system is already inflamed. So if you keep feeding them, that's just going to make them the tummy more upset. Also, we want to perform possible gastric decompression via OG tube to low intermittent suction because, like we said, with the gastric decompression, we're going to either put a nasal tube in the mouth, and we want to, you know, get out. We want to end up trying to get out the fluid and any gas, you know. So we want to put the tube in their nose to go into their stomach to help get out any of that gas that they may have. We want to monitor I's and O's and get them, like I said, we want to keep them nice and hydrated, and we want to prepare the family and the baby for surgery. So those are the nursing actions. Okay, long-term complications. Okay, so long-term complications of this is going to be 20% to 30% of cases are fatal. Short bowel syndrome may occur in neonates with surgical bowel removements. So, but you know, this is something that we kind of hope doesn't happen, you know, but like I said, this is something that could happen. So short bowel syndrome may occur in neonates with surgical bowel removements, and 20 to 30% of cases are actually fatal. So like I said, that's what we've got for that. Okay, so I do hope you guys are doing okay. And like I said, you can always reach out to me with any questions, anything that you may not understand, or anything that you may be stuck on, okay? So, like I said, let me know if you have any questions on anything, okay? Okay, I'm back. I just took a quick break because I needed a drink of water. Hopefully you guys are drinking your water. All right, so now we're on page 563 in the book, if you're following along with me. And we're going to be talking some about persistent pulmonary hypertension of the newborn, PPHN. Dang. Can you say that 5 times fast? Persistent pulmonary hypertension. Say it 5 times fast. I'm waiting. Okay, probably getting more side-eye instead. All right, so this basically results from normal vasodilation and relaxation of pulmonary bed does not occur. This can lead to elevated vascular resistance, high pulmonary artery pressure, right ventricular hypertension, and right to left shunting of blood through foraminal valley and PDA. This can result in hypoxemia. It can result in reduced cardio output, systemic hypotension, impaired tissue oxygenation, metabolic acidosis, worsening vasoconstriction, and deterioration. So that's pretty much what this is, okay? So, like I said, those were the risk factors we just went over. And some maternal factors that could happen. This is non-steroidal anti-inflammatory drugs have been associated with premature closure of the fetal ductus arteriosus, late trimester of SSRI, and has been associated with this as well. With this, you're going to see a lot of respiratory issues, you're going to see a lot of cardiac issues, metabolic issues, hematological issues. Medical management, the main goal is to correct hypoxia and acidosis, give medications like vasopressors and vasodilation, give oxygen as necessary, lab test. And nursing actions, pretty much assess the baby for respiratory issues, respiratory depression, and any other issues, give O2, vital signs. So yeah, so we just kind of went over that just right quickly. So if you have any questions, let me know. But let's go back to our risk factors. I think I skipped. There we go. Here's our risk factors. My bad. I got ahead of myself. Okay, so these are the risk factors. I think I already went over them, but you do want to make sure you know your risk factors for this. Hypoxia, asphyxia, low Apgar scores, respiratory depression syndrome, meconium aspiration, pneumonia, sepsis, hypothermia, use of SSRIs and NSAIDs during pregnancies. And so, like I was saying earlier, your assessment findings are going to be a lot of respiratory issues, cardiac issues, metabolic issues, hematological issues, and the main goal is going to be to correct hypoxia and acidosis. You want to make sure they're going to need an echocardiogram, they're going to need oxygenation, IV fluid, lab tests, surfactant therapy, medications like vasopressors, vasodilations, and then nursing actions are going to be give IV fluids per orders, monitor, give medication, vital signs, give oxygenation as needed, assess for respiratory distress and other complications, and keep handling treatment, suctions, stimulations to a minimum, and providing emotional support to the parents who need it. But the big thing is make sure you know your risk factors. All right. So now let's talk some about small for gestational age and intrauterine growth restrictions. This is on page 564 in the book if you're following along. Now, SGA is not the same as being preterm. I know a lot of people think so. These are just super small babies. So these babies could be full term, they're just really small. So less than 10% of gestational age findings observed clinically, and then you got your intrauterine growth restriction, IUGR. This occurs in utero, and findings are seen by ultrasound. So you're going to be able to see that baby is super tiny, basically. And there's two types. There's symmetric and asymmetric, basically. And there's different reasons why babies will have IUGR. Like symmetric is typically caused by teratogens, congenital infections, and genetic problems. So symmetric is just a reduction in size of structures and organs except for the heart and brain. And asymmetric, basically disproportional reduction in size. This is caused by preeclampsia and severe maternal malnutrition. Okay, so you can kind of see the difference between the two babies. So one baby is actually, I think they're the same gestational age, it's just one baby is normal size and one baby is smaller. So these are your IUGR babies, intrauterine growth restriction babies. They're going to be more at risk for labor intolerance, meconium aspiration, just because they are full term, it's just they're tiny babies, hypoglycemia, hypocalcemia. So these are going to be your risk factors that you're going to see. They may also be due to moms with gestational diabetes. I know a lot of times moms who are gestational diabetics, they have babies that are macrosomnia, but they can have a tiny baby, like multiparity, history of IUGR, preeclampsia, lack of adequate prenatal care, and sometimes use of drugs that they're addicted to. All of these can cause IUGR issues. Assessment findings. Okay, so head is typically going to be large head in relation to the body. They may have longer nails because you got to remember these are still full-term babies. They're just smaller. They're going to have, yeah, so yeah, they're typically smaller babies, but that's due to like different problems like drugs or something. They're going to have a large anterior fontanelle, decreased amounts of Wharton jelly on the umbilical cord. Wharton jelly is the jelly that's inside the umbilical cord. So when the umbilical cord is cut, this stuff that's kind of oozy, that's called Wharton jelly. So they're going to have a decreased amount of that, which isn't good because the Wharton jelly is what protects them, the veins and arteries. They're going to have thin extremities and trunks. They're going to have loose skin related to decreased subcutaneous fat, dry, flaky, or meconium-stained skin because meconium issues. Weight and head circumference and length are all less than 10% of gestational age unless they're symmetric. You know, they have symmetric IUGR. All right, so these are all assessment findings that we're going to end up seeing in these babies. All right, what we're going to do with nursing, we're going to assess for respiratory distress because their lung functions may be still immature. We're going to assess for any growth abnormalities. We're going to assess skin for color and signs of meconium staining. We're going to want to maintain a neurothermal environment because, like we said, if they get cold stress, they're going to be at risk for a lot of problems, okay? So we definitely want to avoid that at all costs. Decrease risk for hypoglycemia. Monitor for feeding intolerance because, you know, they may or may not want to, they may have an uncoordinated suck, they may have gag issues. We're going to want to obtain laboratory tests as ordered, monitor for hypocalcemia, daily weights, and monitor vital signs. So make sure you know your nursing actions for your IUGR babies. Okay, next we're going to look at our bigger babies. These are our large for gestational age babies. Look at the baby, isn't he cute? Isn't baby cute? All right, so these babies, this is going to be on page 566. So these babies are greater than 90% the gestational age. So this is the opposite. Macrosomia baby is going to be greater than 4,000 grams. A lot of times you're going to see this with maternal diabetes, which is the leading cause of LGA babies. Large body with head normal circumference, because you can see how big that baby is, right? All right, so we're going to want to still keep a close eye on these babies because a lot of times with these babies, we see them because of maternal diabetes, multiparity, previous macrosomic baby, prolonged pregnancy, increased maternal weight gain in pregnancy, and maternal obesity. So these are some different risk factors that puts the baby at risk for, and mom at risk for having a large for gestational age baby. All right, so these babies are at higher risk for having to have a C-section just because the mom's pelvis may not be able to accommodate, or they may have to have operative vaginal delivery. They may need to have extra help. And I'm back. All right, so I was talking about babies that are LGA. The baby's going to be at risk for needing a C-section just because the baby may not be able to fit through the mom's pelvis. Or either they may be at risk for like an operative vaginal delivery, like they may need to have additional help coming out, you know, like forceps or either a vacuum. They're going to be more at risk for shoulder dystocia because they may end up fracturing a clavicle as they're coming out through the birth canal. They may have birth trauma, you know, because it could be a traumatic birth just because, you know, difficulty coming out. Like baby could get stuck, and then we may have to end up doing McRobert move because I mean what happens is the head's going to turtle, go back in because baby's stuck. They may have hypoglycemic issues because even though it's a bigger baby, the thing is that doesn't mean they can regulate their blood sugar. So we worry about hypoglycemia, polycythemia, and hyperbilirubinemia, peritoneal asphyxia, respiratory distress, and meconium aspiration, just because like a lot of times the baby's gotten so big that they end up having their first poop in there and then they end up aspirating it. So these are all problems that we worry about for these bigger babies. But they're cute. Okay, so basically we're going to look at assessment Did we already? Yeah, assessment findings. Okay, so birth trauma. We may see molded head or scalp abrasions. And see, this is the thing about our scalp abrasions. Scalp abrasions can end up causing infection because that scalp abrasion, that's what they put in for the to monitor the baby internally, because they have the monitor, those belts that you guys are putting on when mom was anti, but in some cases they have to internally monitor the baby. So, I think that's something different. We're going to talk about that later. So I was thinking that was, no, this is just a scalp abrasion from coming through the birth canal. My bad. Can we get a ooh, ooh? And they maybe have capits. They may have capit or fractured clavicle. So in these babies, we want to kind of palpate for crepitus over the bilateral clavicle area, because in case they have a fractured area. They may have brachia, plexus nerve damage. That's like a nerve damage in your arm. They may have facial nerve damage because of the traumatic birth trauma. They may have a cephalohematoma. They may have a type of hemorrhage, the intracranial hemorrhage, asphyxia. They may be poor feeders. They may have hypoglycemia, polycythemia, and also hyperbilirubinemia. So these are some of the assessment findings that we may see. And see, the polycythemia in neonates of diabetic mothers is related to a decrease in extracellular fluid or fetal hypoxia. And then hyperbilirubinemia, this can occur 48 to 72 hours after delivery related to polycythemia. And this decreases the extracellular fluid or bruising or hemorrhage from birth trauma. So these can lead to all sorts of problems. Okay, medical management. So medical management, we want to assess for any type of birth trauma, hypoglycemia, and respiratory disease, because like I said, all of these can cause problems for the baby. And then we want to do our lab tests such as blood glucose, hematocrit, and bilirubin levels. We're looking for jaundice issues. And like I said, polycythemia, just because if it's a mom that's diabetic, they could have issues as well. So these are all things that we're going to want to do for medical management. Okay, nursing actions. So nursing actions, we want to assess respiratory status, because remember your airway, breathing, circulation. We also want to assess for the neonate, for birth trauma, such as fractured clavicles. And like I said, like if you're trying to do like the Monroe reflex and the baby's not able to lift their arm up, you might want to check for fractured clavicle. So you want to palpate for crepitus, So like I said, you're going to maybe want to know stuff like that. We're going to want to assess for brachial nerve damage, facial nerve damage, cephalohematoma. We want to monitor blood glucose because we do worry about hypoglycemia in these babies. Look for signs and symptoms of hypoglycemia. What are signs and symptoms of hypoglycemia? Any takers? I don't see any hands. Put your hands up. Yeah, I'm probably getting side-eyed. So you want to look for jitteriness, tremors, lethargy, anything like that, because those are signs and symptoms of hypoglycemia. Also provide early and frequent feeding. You also want to monitor hematocrit levels, assess skin for signs of polycythemia, such as red, reddy color, perform the gestational age assessment at the hospitals where they do that, and also observe for jaundice issues. So that's going to be our LGA babies, the bigger babies. And then we also want to take a look for facial damage. So yeah, so sometimes babies do have facial damage just because sometimes they have problems, like birth trauma. Birth trauma can cause facial damage. So these are things that we're going to want to look for in our babies, actually, because look at the poor baby's face. Can you see what's wrong? Can you see what's wrong with the baby? I mean, you can kind of see how the baby's mouth is kind of off to the side. So yeah, so these are things. So this is a picture of your facial nerve injury. So you'll want to, document that as well. Okay, brachial nerve damage. Okay, so this is just a picture of what brachial nerve damage looks like. So you can kind of see how the baby kind of holds their hand in a claw-like manner, and the baby can't really use their arm. So what we'll have to do is pin an arm sleeve to the front of the shirt or place arm in sling, and you don't want to pick up the baby under the armpit area because that's going to cause more damage. But that's just a picture, of what we can see in our babies that have like the nerve damage issues or either facial trauma. This is just kind of what it looks like, because I know that that you guys are visual learners. Okay, and then this is also your clavicle trauma. Okay, so you see how the bone is kind of broken here. You can see how the bone is kind of fractured. So what you want to do is palpate for crepitus over bilateral clavicles, because that's going to be an indication that there's possibly a fracture there, So you want to palpate, for crepitus. So these are things that you're going to want to know. Because like I said, if they try to do the Monroe reflex and they can't lift their arm up, there's a good chance that something was broken. Assess for any pain. How can babies show that they're having pain? They can cry, they can grimace or whatever, So, you want to assess for pain issues and give pain meds as needed. All right, and then this is just a picture of a cephalohematoma. So basically, sometimes they may end up you may see this because, being born and having issues coming out. So this is a cephalohematoma. It will eventually end up going away as well. All right, now we're off to hyperbilirubemia. All right, yay! Hyperbilirubemia. You're like, why are you yaying? Well, yay anyway. Ooh, ooh. Okay, so I'm pretty sure that everybody has had a chance to see jaundice, what jaundice looks like. In babies, neonatal jaundice is yellow-orange tint that can be visualized in the sclera and the skin of the neonates with hypobilirubemia. And this is increased bilirubin in the blood. So this is on page 567 if you're following along. So like we said, what you're going to see is you're going to see sclera and skin of neonates is turning yellow-orange. Total serum bili is both unconjugated, direct and indirect. Unconjugated bili can cross the blood-barrier brain and cannot be excreted and settle into tissues. Jaundice serum levels greater than 5 complicates. Sometimes you have complications. You may have acute bilirubin encephaly and kernicterus. There's 2 categories. You're going to have either physiological jaundice or pathological jaundice, okay? So physiological jaundice results from hyperbilirubemia that commonly occurs after the first 24 hours and during the first week of life. It's caused by the breakdown of red blood cells, and basically they're going to just be increased for hemolysis and physiological jaundice. And then pathological jaundice results when various disorders exacerbate physiological processes that can lead to hyperbilirubemia. So one happens after 24 hours, within the first 24 hours, and then the other one, this one is from different disorders that can lead to this, basically. Okay, so let's start with physiological jaundice first. So physiological jaundice, hyperbilirubemia, occurs after the first 24 hours. Is caused by the breakdown of red blood cells. Total bilirubin peaks on day 3 of life in term neonates and between 5 to 6 in preterm neonates. Progresses in a downward fashion starting from the head and moving to the feet. So a lot of times you're going to see the jaundice in the face first, and then it's going to go down to the chest, and then down to the legs. Okay, pathological jaundice. This is hyperbilirubemia in the first 24 hours. This one is not normal. It may be due to pathological. Okay, so causes are congenital malformation, infection, metabolic disorders, medications, shock, ABO incompatibility. Do you guys remember what that is? I know that you guys talked about it earlier. So with ABO compatibility, mom's blood type may be O negative, the baby's blood type may be A positive. ABO incompatibility, the mother has O type and baby has blood type A or B. So the RH incompatibility, the mom is RH negative and the baby is RH positive. So you do want to make sure you know stuff like this, okay? So make sure you go back and review that mom ABO compatibility. This also puts the baby at risk for jaundice. Okay, and then also bruising, intravascular hemorrhage, cephalohematoma, all of those things can be caused by pathological jaundice. All right, medical management. Medical management, we're going to do we're going to be doing the I think that's like a transcutaneous serum bili. That's the device that we take to check the bilirubin. Now, it's not the serum bili. The serum bili is the heel stick. The transcutaneous bili is this device that we take and we just press it down on the baby's chest 3 times, and it gives us the bili level. But if it's too high, then we need to follow up with a heel stick for a serum bili, which is a blood test. We also want to do the Coombs test or whatever. We want to do CBC. The reticulocyte counts, as well as, and the serum bili, we have to look that up, because there's actually a website we go to, and it's going to tell us if the bilirubin is normal or abnormal. We want to look at how many hours the baby was born, and that's all going to take, that's all going to play into the function. Okay, so so if we have a high direct bili, that's going to be, we're going to need to do further medical management for that. All right, it's not letting me go back. I think I skipped something. Did I skip? No, I think we're okay. Okay, yeah, this is 65. Okay, so medical management. So we're going to need to do our medical management. First, I believe we're going to have to get our bilirubin. We have to test the bili levels. Then we may need to do a phototherapy. So phototherapy is when we have to put the baby under the bili lights. They're these blue lights. The baby has to stay under there. We put like a little blindfold. I don't want to call it a blindfold, but we put like a shield over the baby's eyes, and the baby is only going to be wearing a diaper, and we put them up under there. We'll check for vital signs. It's nice and warm under there. Babies don't like it under there, but you have to leave them under there, or else they're not going to get better. They can come out for feeding, breast or bottle feeding, but then they have to go back under there. We change their diapers. The plan is for them to pee and poop out the jaundice, okay? Because we have to feed them often, check their diapers often, because like the lights are supposed to go in and break up the bili so they can pee and poop it out. But if you don't leave the baby under there, the baby's not going to get better, and then we have to do follow-up bilis. Then we also do, in some cases, they may need an exchange transfusion. In some cases, I've actually never had to see an exchange transfusion, but like I said, it just kind of depends on what's needed. But yeah, so exchange transfusion is used in cases where phototherapy is not effective or severe hemolytic disease is pregnant. And in the exchange transfusion, this procedure, the neonate's red blood cells are replaced with the donor cells, which can reduce the serum bili levels by as much as 50% of the pre-exchange level. And we may need to do IV NIG for ABO incompatibility. So it's intravenous immunoglobulin. This is for hyperbilirubinemia caused by isoimmune hemolysis, has shown to be dramatically decreased for the need for the exchange for transfusion, and that's extreme levels. Typically, babies just need to have phototherapy, and after phototherapy, we do follow-up bili, and then they can usually go home. And we'll follow up with the pediatrician 72 hours later, okay? But like we said, we check our bili. Then if it's high, we have to get like a serum bili, and if that's high, then we do phototherapy, and then after so many hours we recheck the bili, and if it's going down, then we just kind of we stop the lights per the doctor's orders, and then if it still continues to go down, they can go home. But these other things like the exchange and the IV NIG, that's like in extreme cases. All right, nursing actions. All right. So we want to assess the degree of jaundice with the transcutaneous bili. So we have to check the bili, check their bili level first. We can usually see the jaundice in the baby. Like I said, a lot of times it starts at the head. You can just put your finger on the baby's head and then blanch the skin. And if the baby looks yellow, you also check the chest as well. So you visually check for the yellow. Now, if it's a baby of ethnicity, you can see the yellowness in the sclera. You want to document your assessment findings. You also want to notify the doctor if bili is present. You need to obtain a serum bili, which is a blood test if ordered. You want to make sure the baby is eating, hydrating. So feeding should be every 2 to 3 hours, because the idea is for the baby to pee and poop the jaundice out. Implement phototherapy as ordered, because the sooner we get the babies under the lights, the better. We want to position the lights 12 to 16 inches away from the baby. Place baby under phototherapy with only a diaper and eye shields, because we need to be able to get the lights on as much of this skin as possible. We need to remove the eye shells every 4 hours to assess the skin and eyes. But the baby needs to not be under the lights when you take that eye shield off, because the belly lights can damage the baby's eyes. We want to monitor I's and O's and vital signs. So you want to make sure you know your nursing actions for hyperbilirubinemia. And like I said, we want to make sure that they are avoiding the stooling, because that's going to help the baby to pee and poop the jaundice out. So this is what phototherapy looks like. I'm not sure if any of you guys were able to see this in clinical, but yeah, these are the phototherapy lights, and the baby has to be on them. And like I said, it has to be close enough for the baby to be able to get to a large amount of the skin. And it's best if parents do not mess with it or to keep taking the baby out, because I have had parents who wouldn't leave the baby under, and so the bilirubin couldn't go down, so they had to stay longer. So we don't want that, okay? But that's what therapy looks like. And we also have something called Billy blankets that we may use as well. Okay, neonatal infections. So let's go ahead and talk about neonatal infections. So the neonatal infections, we said that babies are super at risk for infections, right? You know, they're super at risk for infections just because they are so small, and then they have the weak immune system. So we do worry about infections for babies. So that's why we kind of have to keep a close eye on them. So neonatal infections on page 573. So babies may be symptomatic at birth and develop symptoms within the first few days of life. Risk factors are possible. The thing about infections among babies, they're the leading cause of morbidity and mortality due to the immune system of a neonate being super immature, like I said earlier. So we do worry about, we want to look at the history of STIs in moms, prolonged rupture of membranes greater than 12 hours, because that can cause infections for mom and baby, vaginal GBS, maternal temperature during labor, because what did we say? We said if mama has a temperature, that could be indicative of infection. Difficult or prolonged labor, that can cause stress to the baby. Fetal scalp electrode. So this is what I was trying to talk about earlier. So basically, you know how we had to put the monitor on the mamas to monitor the baby still in utero when they came in for labor? So in some cases, we have to internally monitor the baby. So we take the fetal scalp electrode and we place it on the baby's head, and this can monitor the baby from in utero, but that does leave a fetal scalp electrode mark. So the baby can get an infection from that. Meconium staining and length of stay in the hospital, because hospitals are full of infections. So you do want to make sure you know your risk factors for neonatal infections, okay? Make sure you have a good understanding of that, okay? Because we worry about neonatal sepsis, and that's a systemic illness by bacteria within the first 28 days of life. So that's what we do worry about for the babies. Okay, GBS. You know, I know that you guys are familiar with GBS status for mamas, but see, the thing is, it's more bad for babies. So this is on page 574 in your book if you're following along. And so basically GBS, this is the cause of neonatal meningitis and sepsis. So that's why we worry so much for the mom. So all women are screened between 36 and 37 weeks gestation. But what if your mom has no prenatal care? That's something to think about as well. Okay, so if a woman is GBS positive, they will receive antibiotics during labor. They need to receive 2 doses of antibiotics, the last dose given over a 4-hour period prior to the delivery. If they get those 2 doses before the 4-hour window, over the 4-hour window, we're good, okay? But like, they can be treated with penicillin or cefazolin if they have a penicillin allergy, okay? But if women are status as GBS unknown, we treat them as if they're positive. Because like I said, sometimes patients don't have prenatal care, or sometimes a woman may not have prenatal care and she's just a stop and drop. She just comes in and has the baby. Now what? So what we do in those cases, like I said, we treat all women as if they're unknown. If a woman is GBS unknown, we treat them as if they're positive. And if a woman does have GBS and they are not treated, then what we have to do is we have to kind of keep an eye on the baby. The newborn's going to need to be assessed for signs and symptoms of infection to prevent sepsis. And some hospitals, what they're going to do a CBC blood culture on the baby just to be sure, okay? So like I said, if a woman is GBS unknown, we treat them as if they're positive, and we'll go ahead and give them the 2 doses of antibiotics prophylactically. And if the GBS they were not treated at all and the baby came, then we need to just go ahead and keep an eye on the baby. So you may have some cases where you have a woman who didn't have prenatal care and they did not get the antibiotics and they had the baby. So what we're going to do is monitor the baby and assess for signs and symptoms of infection to prevent sepsis. And like I said, at some hospitals we'll do CBCs and cultures on the babies just to be sure. So you do want to make sure you know your GBS positive. You want to know your GBS infections and make sure you know what to do if the mom is not treated or whatever, what you need to do. Because the most important thing we worry about is the baby, because this is going to affect the baby. So we need to assess the baby for signs and symptoms of infection to prevent sepsis, okay? So make sure you know your GBS infections, okay, and what we do. All right, now substance abuse. All right, substance abuse for babies. Now, I know that this is really difficult, it really is, because nobody wants to see a baby, going through withdrawal. So this is actually on page 577, 578 in your textbook for the babies, okay? So use of tobacco, alcohol, and other illicit drugs during pregnancy is a no-go, okay? Infants may experience a wide range of withdrawal symptoms. I'm not sure how many of you guys had a chance to see baby withdrawal, but it's not pretty, is it? They cry, they're fussy, they're moody. So, infant withdrawals are referred to as neonatal abstinence syndrome, NAS, or neonatal opioid withdrawal syndrome. Now, as substances that can cause neonatal abstinence syndrome are opioids, barbiturates, and miscellaneous, okay? So these are things that's going to cause it. So signs and symptoms of neonatal withdrawal. And you are going to want to know your signs and symptoms of neonatal withdrawal. You may see apnea, you may have loose stools, diarrhea, excessive crying, excoriated skins like newborn rash, fever, high-pitched cry. High-pitched cry is going to be your classic signal. I've seen lots of babies and they're very consolable, and it's that cry you'll never forget. You may see hyperreflexia, hypertonia, increased rooting, flexing, frantic sucking, irritability, nasal congestion, sneezing, poor feeding, possibly seizures, sleeping problems, sweating, tachypnea, tremors, vomiting, weight loss, hiccuping. So when we have to do the scoring sheet, because we do have to kind of give them, when we use the Finnegan, and we have some hospitals have different withdrawal scoring sheets, we're looking, I think we have to do it every 4 hours, but we're looking at the signs and symptoms of the baby. But like I said, high-pitched cry, that's going to be your classic giveaway, but you do want to make sure you know your signs and symptoms of this, okay? All right, so this is called the Finnegan scoring sheet. Most hospitals use this basically, and basically you're going to go in and you're going to give your baby a score based on what they're going through, okay? So let's take a look at it together. All right, so basically it's got, I'm not going to actually read this to you, but like I said, you can go in and you can kind of give your baby a score based on the signs and symptoms they have, and you have to write in the time, and different things are scored by either a 1 or a 2, and you have to put in the time, because like I said, most hospitals is every 2 hours. But yeah, so this is basically what we're going to use to monitor the baby's signs and symptoms to see if they're getting worse, okay? And a lot of times when babies are first born, you may not see the signs and symptoms as much, but then as they start to age, then they're going to get more and more and more. They're going to become more irritable and more fussy. So the Finnegan Neonatal Abstinence Scoring Tool, this is the most commonly used score, and the points are assigned, producing a score that can be helpful with pharmacological treatment. Scores obtained every 3 to 4 hours, and like I said, in some cases they may have to end up going to NICU for treatment, because they may have to put them on a low dose of a medication to kind of help them with weaning off. All right, so these are going to be the actions that we're going to do. We're going to monitor the vital signs. We're going to get toxicology screenings as ordered. We're going to have to get a stool and a void, because we have to send it off to toxicology. And a lot of times, like the parents, sometimes will try to mess with the baby's voids and stools. So a lot of times we say, we'll come in and change the diapers, because we don't want them really messing with it, because they know good and well that we're looking. And a lot of times they'll go in and try to take the bag off, because you have to put a bag on the baby's genital areas, so that you can collect the void, and then you send that down to the lab. And then also the diaper, you just take the diaper, you want to get the first meconium, and then you just take a 10 blade and then you scrape it into a cup or whatever, so we can sit and label it correctly and send it down to the lab. And then we're also going to assess for signs of withdrawal, use a Finnegan score or another type of scoring sheet so that way we can keep up with how they're doing. So we want to assess for neonatal abstinence scoring tool, and then we want to report the high scores to the doctor so that way we can plan for care. Okay, and then we also talked some about the genetic disease screening. I hope you guys are doing okay. I do. We talked some about the genetic disease screening. This is typically, and you do want to make sure you know this information, okay? This is a need to know as well. So this is completed prior to discharge, again within 2 weeks of birth. Tests for genetic disorders that can be managed by diet. Infants must have PO intake of formula. And also, or breast milk. This needs to be done before the test because since they're going to have to bleed, we want them to be nice and hydrated. Disorders tested are for PKU, which we talked a lot about that last week. Also, congenital adrenal hyperplasia, galactosemia. Galactosemia, that's actually a disease that basically like it's affected by diet, so they have to have a special milk. And this is going to vary by states. So the thing is, you do want to make sure you know this. Make sure you know what we need to do before we end up giving the test. And this is the one where we have to do the heel stick, okay, the GDS, okay. And so, like I said, this is why they have to be done, had something to eat before this because we want them to be nice and hydrated. So they have to fill up all 6 of these dots, just like that. You can't have a dot half filled in or else it's going to get sent back. So think about, where do you need to do the heel stick? Remember where I showed you in my last PowerPoint? Where do we need to do the heel stick? I mean, the heel stick is typically going to be on the sides because if you go sticking anywhere, then that could cause some kind of nerve damage. So make sure you know where we need to stick the baby, and make sure you know what are some things we need to do before. This is typically completed prior to discharge, and then again within 2 weeks they have to do a follow-up. A test for genetic disorders that can be managed by diet. Infant must have PO intake of formula or breast milk before the test can be done, and disorders are usually tested for PKU and galactosemia and others. So make sure you know these things, okay? Okay, infant car seat challenge. Now, I know when we were going over the study guide, people were like, what's that? What's that? This is the thing about, and I did try to explain it to you guys best as possible as I know what this is, but basically your infant car seat challenge, this is what we're going to do for our preterm babies, okay? And like I said, I think I did talk to you guys about it when we were doing the study guide, but basically this is for our preterm babies. All babies get this before 37 weeks. So we put the baby in the car seat for at least 90 to 120 minutes, basically the length of where they live, or the length of the hospital, whichever is longer. Most of them are 2 hours and less than. And so what we do, we have them hooked up to the pulse ox, and we're watching them. We're watching the heart rate, the oxygenation, respiration during the car seat trial, because we want to make sure that when they go home that the baby's not going to be deciding. Because you got to remember where the crib goes. The crib is in the back seat. Hopefully we put it in the middle and it's rear facing. We can't see the baby. So if baby's turning blue and having desats, we're not going to know. So this is why we do the car seat challenge. It's for preterm babies, and we're monitoring the baby, for the length of the car ride home or the length of travel to make sure that baby can handle it. Because if baby's deciding, that's a no-go, okay? So like if baby does fine, they pass, but if they're they can decide maybe every now and then, but we don't want to touch the baby too much because like if the baby's head lops over, what's going to happen if they're in the car driving home? So that's why you kind of want to have them propped up, put in there nice and secure. But if they're deciding the majority of the trip home, then we may have to do a redo, or they may need to get them. And if they still fail, then they may have to get another car seat because baby's not doing well with that car seat. But you do want to make sure you know your infant car seat challenge. And like I said, I did explain this during Skills Lab with you guys. But that's going to be the car seat challenge, okay? Okay, contraindications to breastfeeding. And this is also a need to know. So babies diagnosed with galactosemia. So we're going to know that they were born with galactosemia from the PKU, or the genetic screening test. And like I said, galactosemia, this is a condition where basically babies cannot break down galactose, which is in breast milk and bottle feeding. So they're going to need a special formula for this basically. Babies, if they have active and untreated tuberculosis, if they have active herpes lesions on the breast, if they receive treatment with, if like the mom is receiving treatment with radiation, if mom is receiving treatment with anti-metabolites and also chemotherapeutic agents, mom was using illicit drugs, mom is HIV positive. These are all reasons why moms should not be breastfeeding, okay? So this is it. You definitely want to make sure you know this, okay? All right, feeding cues. I know we talked about this last week as well. So feeding cues, when do, a lot of parents are like, how do I know when baby's getting enough? Well, because they need to know parents need to know when the baby's hungry. So feeding cues typically happen for up to 30 minutes before the infant begins to cry, because crying is a late sign. So you'll see smacking of the lips, smacking of extend their tongues, putting their hand in their mouth, sucking on their fingers, turning their head to mom's voice, entering a quiet, alert state. But basically, you're going to see them, sucking, smacking on the lips, putting their hands in their mouth, sucking on fingers, turning to look at the mom. So these are all your hunger cues, basically. And this happens 30 minutes before they cry. Because when the baby's crying, now they're mad, and it's going to be harder to console them. Okay, and then also, I know I taught some about this during the study guide review, latch assessment. So this is your latch assessment tool, and I know we taught some about it, and you are going to want to know this. But see, this is the latch assessment tool that we end up doing for our babies, and the moms to see how well they're breastfeeding. L represents how well the infant latches to the breast. A represents audible swallowing. T identifies the type of mother's nipple, C represents the mother's degree of comfort, and H describes the amount of assistance needed to hold or position the newborn at the breast to maintain an effective latch. So this is an assessment tool that we end up using to assess how well baby is breastfeeding. So, yay, we made it to the end. Can we get a ooh, ooh? And also, I know we've talked some about the about feeding, babies feeding, so nutrition. I know I taught some about that last week with you guys during the study guide review. So, like I said, this is everything, and we are hopefully going to try to go over some more of the study guide after Skills Lab, okay? But anyway, if anybody has any questions or wants to meet with me or anything you didn't quite get, let me know. I hope everything went well with this. I'm hoping nothing cut out on us, because like I said, I've tried to record this like 3 times already, but I hope everything is good, and if you have any questions, be sure to let me know. And it is your responsibility to watch this and review this before we do our exam review, okay? Because like I said, I mean, I need to make sure that you guys know this, okay? So please don't wait till the last minute. And that's why I'm just trying to get this posted before Monday, so that way you guys had some time. Okay, but anyway, I hope that everything came out okay. And if you have any questions, let me know. Thank you guys for putting up with me, and you guys have a wonderful rest of your day. Can we get a ooh, ooh? Okay. Anyway, you guys, today is Friday, that's when I recorded this. So happy Friday, everybody, or happy whatever day it is you listen to this.